Swayam Prabha. Digital India. Educated India.
Good morning everyone. Today I'll be discussing demyelinating diseases of the CNS. The term demyelination is applied to a group of conditions in which there is focal myelin destruction with relative sparing of axons. It can be divided into two main categories. Number one, the diseases in which there is extensive destruction of normally formed myelin, and number two, diseases in which there is defective myelin formation. Primarily, the diseases which occur to the destruction of myelin can be of two main types, namely acute disseminated encephalitis or ADEM, which occurs mostly in post-viral conditions or after a vaccination, and its variant includes acute hemorrhagic leukoencephalitis. The second most common demyelinating disease is multiple sclerosis, and other miscellaneous demyelinating diseases include central pontine myelinosis and progressive multifocal leukoencephalopathy. So, I will be discussing these diseases one by one. Now, acute disseminated encephalomyelitis, the name itself tells you that it has an acute onset and it involves CNS in a disseminated manner, that is, there is extensive involvement of the CNS, but dominantly the disease occurs in the white matter. So, what happens in the disease is that the body's own immune system starts attacking its own brain, which is triggered by an environmental stimulus, and most of these patients are genetically susceptible. Occurs primarily in a young aged patients, mostly children and young adults, and the disease occurs after 1 to 2 weeks of insult. So, it can be after a viral fever like measles, rubella or varicella infection, or it can be post vaccination illness. For example, a patient has been given an old rabies vaccine, hepatitis B vaccine, Japanese V encephalitis vaccine, DPT, measles, mumps, rubella, etc. The disease is mostly acute in onset, and more than 85% of the patients, they recover from their illness, and in 15 to 20% cases there can be death of the patient. Grossly, there is grayish discoloration in the white matter which is mostly disseminated, and microscopically the lesion starts in the perivascular white matter region, and there would be infiltration by mononuclear cells, macrophages, and there would be relative sparing of axons. The exact pathogenesis of the disease is not known. It has been thought that it is an immune mediated damage to the myelin by T lymphocytes, and the variant of ADEM, that is acute hemorrhagic leukoencephalitis, is mostly acute in onset. It also affects young children, but it has a very high mortality, and in addition to demyelination you can have hemorrhagic necrosis of the brain. So, I will be showing you some pictures. This is a gross picture of a coronal section of the brain showing you areas of demyelination. One can be seen here, and small areas of demyelination can be seen in this side also. This is an HND stained section showing you an area of rarefaction, and this is a section which has been stained by Luxol fast blue, which is a stain used to depict myelin. So, this side you can see the myelin is relatively preserved, but here the area of rarefaction which is seen in this HND stain section is not stained by Luxol fast blue. So, that means that there is demyelination in this area. So, these are the HND stain sections showing you extensive perivascular chronic inflammatory infiltrate, mostly comprising of lymphocytes and macrophages, and there is area of rarefaction which is due to demyelination. And this is a picture showing you extensive macrophage proliferation and lymphocytic infiltrate around perivascular zone. This is a Luxol fast blue stain section showing you loss of myelin in this area, and this is IHC for LCA, which is showing you that most of these cells are comprising of lymphocytes. So this is a gross picture from a case with acute hemorrhagic leukoencephalopathy. So you can see there is disseminated petechial hemorrhages are seen in the brain, and there are areas of hemorrhages, and even in H&E stain section you can see areas of hemorrhages. Otherwise the picture is similar to the ADEM pathology. Now coming on to the second most common cause of demyelination, which is multiple sclerosis. Multiple sclerosis is, in contrast to ADEM, is a chronic demyelinating disease. Otherwise the pathology is similar to ADEM, but this is a chronic demyelinating disease, mostly affects people between the age of 10 to 15 years with a mean age of 30 years. It's very rare in young children and in elderly population. It can either have, mostly it has a relapsing and remitting course with periods of exacerbation and remission, or it can have a chronic progressive course, and it is commonly seen in North America and in European countries, but it is rare in Asian countries. Multiple factors play a role in pathogenesis of multiple sclerosis. The most important factors which have been shown to have influence in causation of multiple sclerosis include: number one, environment. It has been seen that if a patient younger than 15 years migrates from a low risk to a high risk area, that person has a very high risk of having multiple sclerosis. But if a person, who's more than 15 years shifts to a high risk area, the risk is low. So it suggests that in an early age there is some role of environment or some infectious agent which plays a role in pathogenesis of the disease. The second important agent which has been implicated for causation of multiple sclerosis is various types of viruses, but till now no virus has been named or isolated as such for causing multiple sclerosis. It has been seen that there has been reports of familial aggregation of the disease. There is increased risk in second and third degree relatives, and in monozygotic twins the risk of concordance is as high as 25%. So genetic predisposition has been seen in patients with multiple sclerosis. And fourth factor which plays role in multiple sclerosis is immunological factors. There is a possible role of cell mediated immunity in these patients. Clinically, most of the disease occurs dominantly in the white matter. Patient can present with wide range of symptoms, and at any given time there can be involvement of two or more separate areas of the CNS. And if you look at CSF, there can be increased pleocytosis, increased protein, and increase in the gamma globulins. Now if you look at the histology, mostly what you see is plaques which can be multiple. They are sharply circumscribed and variable in size, mostly occur in the white matter and dominantly in the starting point is the periventricular region in the angles of the lateral ventricles. So this is a gross picture showing you plaques in the periventricular region over here, and one is seen over here. Now if you look at the H&E stain section, what you see is dominantly there is perivascular chronic inflammatory infiltrate. This is surrounded by areas of rarefaction. This can be seen in an H&E stain section, and sometimes you can see reactive gliosis, lymphocytic infiltrate, and foamy macrophages which can be seen even on H&E. And this is a Luxol fast blue stain section showing you a pale area in the perivascular region. This corresponds to what is seen in this picture, and this is the area of demyelination. So Luxol fast blue is a stain which is used to depict myelin. So in this section you are seeing myelin loss, and there is extensive reactive gliosis which has been highlighted beautifully by using immunohistochemistry for GFAP. Again, so the hallmark is perivascular inflammation, area of rarefaction, and extensive reactive gliosis. This is immunohistochemistry for myelin basic protein, which is highlighting areas of demyelination. You can see a pale area in this slide as well as in this slide. So demyelination can be depicted either by histochemical stain named Luxol fast blue or immunohistochemical stain named myelin basic protein. if you do immunohistochemistry for neurofilament protein, which actually stains the axons, this shows that there can be some amount of axonal destruction also, but mostly there is sparing of axons in demyelinating diseases. Now coming on to a very important, other important cause of demyelinating illness, which is actually an infectious disease. It is known as progressive multifocal leukoencephalopathy. So the name itself tells that the disease is, number one, progressive. Number two, it is multifocal, so it involves various areas in the white matter, and leukoencephalopathy means it dominantly involves the white matter. So it mostly occurs in immunocompromised patients, and most of the cases with PML are the patients who have AIDS, and the virus which is implicated mostly in these cases is JC virus. So what you see is extensive demyelination, chronic inflammation, and in addition you can have inclusions in oligodendroglial cells, and you can have hypertrophic large bizarre astrocytes. The disease has relentlessly it progresses, and it has fulminating course, and most of the patients die within 3 to 6 months. So these are some of the pictures. Again, this is HND stain section showing you areas of rarefaction and infiltration by foamy macrophages. There is extensive reactive gliosis. Demyelination again can be highlighted by immunohistochemistry for myelin basic protein, reactive gliosis by immunohistochemistry for GFAP. So this is a picture showing you intranuclear inclusions in the oligodendroglial cells, and this is another picture showing you bizarre atypical astrocytes. Another cause of demyelination is central pontine myelinosis. This is a very distinct disease which occurs as a complication of rapid sodium correction, and the demyelination dominantly occurs in the central part of the pons and mostly occurs whenever there is osmotic correction. Now coming on to another important cause of demyelination, we should rather call it as dysmyelination, because there is ill-formed, or you can say defectively formed myelin. So it's a group of disorders which is characterized by degeneration in the white matter in the brain due to defective formation of the myelin, and these are basically genetically, there are some genetic enzyme defects. The diseases can be classified as number one, metachromatic leukodystrophy, number two, Krabbe's disease, and third is adrenoleukodystrophy. The diagnosis can be made by seeing the degeneration of white matter in the MRI. Patient usually presents with decreased motor functions, muscle rigidity, and eventually degeneration of sight and hearing. And if the disease presents in an infant, then the lifespan is usually 2 to 8 years, and if it presents in adults, they typically live more than a decade after the onset. Thank you.